Coagulation, disorders of primary hemostasis. Clinical manifestations. Symptoms are the manifestations of a disease that are apparent to the patient. Signs are manifestations of the disease that physicians perceive. Petechiae are purplish, red, pinpoint hemorrhagic spots caused by the loss of capillary ability to withstand normal blood pressure and trauma. Red cells leak out through intact endothelial lining of the capillaries into the tissues. Usually occurs on the extremities because of high venous pressure. They arise without trauma, are painless, and accompany abnormalities of platelet and blood vessels. Purpura, or bruises, are the hemorrhage of blood into the small area of skin, mucous membranes, and other tissue. Purpura is used to describe both petechiae and ecchymosis. They appear red at first due to blood, but turn green due to the conversion of hemoglobin to biliverdin and then to bilirubin. Ecchymosis is a form of purpura in which blood escapes into the large area of skin or mucous membranes, but not deep tissue. In ecchymosis, bruises are larger than 3 millimeters. They are red or purple in color when first formed and become yellowing green with age. They may appear spontaneously or with trauma. They may be painful, and they may occur in abnormalities of blood vessels, platelets, or coagulation factors. Hematoma, or bruise, is a swelling or tumor in the tissue or a body cavity that contains clotted blood. Hematomas occur when blood leaks from an opening in a vessel and collects beneath intact skin. It is blue or purple in color and slightly raised. It can occur in any organ or tissue and may be in the form of a clot. Hemoarthrosis is bleeding into a joint cavity. Epistaxis is a nosebleed. Menorrhagia is excessive menstrual bleeding. Platelets, a normal reference range of 150 to 400,000. Thrombocytopenia is an abnormally low level of platelets. Thrombocytosis is an excessive number of platelets. Thrombocythemia is a disease in which bone marrow makes too many platelets. Quantitative defects have to do with platelet number or count. Thrombocytopenia is the decreased production of platelets, or increased destruction or utilization, which can be non-immune or immune. Thrombocytosis is seen in myeloproliferative disorders and secondary to other disorders. Qualitative defects are abnormal function. Von Willebrand's disease, Bernard-Soulier syndrome, Glanzmann's thrombocythemia, aspirin, abnormal appearance, and artifacts affecting platelets are all qualitative. Laboratory testing of platelets includes a platelet count, bleeding time, a platelet function assay, clot retraction, and special tests. A platelet count is the number of platelets in a specimen. It can be found using an analyzer. During a slide scan, you count 10 fields on 100 times the average and add a 0 to the end. Bleeding time measures platelet function, but has been replaced by platelet function assays. The bleeding time principle: a standard incision made of the collar surface of the forearm, and the time it bleeds is measured. Cessation of bleeding indicates the formation of a hemostatic plug. This shows an adequate number of platelets and ability to adhere to the subendothelium. The incision is made 3 millimeters deep. Filter paper is applied every 30 seconds until cessation of bleeding. Normal is 1 to 9 minutes. 9 to 15 minutes indicates platelet dysfunction, and greater than 15 minutes is critical. Hereditary defects are von Willebrand disease, which involves either the quantity or functionality of von Willebrand factor, Glanzmann's thrombocytopenia, which is a GP2B3A deficiency and is autosomal recessive, Bernard-Soulier syndrome, which is a deficiency of GP2B910 deficiency. It is autosomal recessive and characterized by giant platelets with perceived thrombocytopenia and connective tissue disease. Acquired platelet defects are thrombocytopenia, vitamin C deficiency, medications, alcohol intoxication, liver failure, leukemia, uremia, and myelodysplastic syndrome. A platelet function assay measures platelet function with collagen, ADP, and epinephrine. It is sensitive to aspirin, von Willebrand disease, and ADP receptor problems. Platelet function tests are a group of assays that use specialized equipment to measure the ability of platelets to aggregate and promote clotting in a sample of blood. There are a variety of tests available, but no one test that identifies all problems with platelet function. Clot retraction evaluates platelet function, fibrinogen, red cell volume, and fibrinolytic activity. Decreased clot retraction correlates with anemia and hypofibrinogenemia. A rapid dissolution of the clot indicates increased fibrinolytic activity, or DIC. Glanzmann's thrombasthenia involves no clot. In Glanzmann's thrombasthenia, the number of platelets and the morphology are both normal. It has abnormal platelet aggregation because all agents are decreased, but von Willebrand factor is normal. Bernard-Soulier has a moderately decreased number of platelets, and the morphology shows giant platelets. It has abnormal adhesion because ristocetin is decreased, and a normal von Willebrand factor. In von Willebrand's disease, the number of platelets is usually normal, and the morphology is usually normal. Assays show abnormal adhesion because ristocetin is decreased, and an abnormal von Willebrand factor. Aspirin inhibits the secondary wave of aggregation because it destroys cyclooxygenase. Clotting factors. The intrinsic pathway, which is measured by APTT. This pathway is associated with spontaneous internal damage and includes factors 12, 11, 9, and 8. The extrinsic pathway, which is measured by the PT, is associated with secondary internal trauma and includes factors 7 and 3. The common pathway includes factor 10, 5, 2, 1, and 13. The liver produces the majority of the clotting factors. Factors 13, 12, 11, 10, 9, 7, 5, 2, and 1. Factors 8 and 3 are produced by endothelial cells. Factor 6 is produced in plasma, and factor 5 is produced by the megakaryocytes. Factor 1 is also known as fibrinogen. Factor 2 is known as prothrombin. Factor 3 is tissue factor or thromboplastin. Factor 4 are calcium ions. Factor 5 is proaccelerin. Factor 7 is stabilizing factor. Factor 8 is anti-hemophilic factor A. Factor 9 is the Christmas factor, or anti-hemophilic factor B. Factor 10 is Stewart-Power factor. Factor 11 is plasma thromboplastin antecedent and is also associated with antihemophilic factor C. Factor 12 is Hageman factor, and factor 13 is the fibrin stabilizing factor. Serine proteases are enzymes that cleave peptide bonds in proteins in which serine serves as the amino acid at the active site. They are factor 2, 7, 9, 10, 11, and 12. The vitamin K dependent factors are factor 2, 7, 9, 10, and protein C and S. If vitamin K is decreased or not present, these factors will not be functional. The same result is observed in warfarin therapy. Cofactors. Factor 8 binds to factor 9A by calcium to the platelet phospholipid membrane. Factor 5 binds to factor 10A and protein C and S. The intrinsic pathway is activated by factor 12, which is induced by collagen in the presence of high molecular weight kininogen. It then activates factor 11, which activates factor 9 with its cofactor, factor 8. During the extrinsic pathway, external damage causes factor 7 and its cofactor tissue thromboplastin, or factor 3, catalyze factor 10, which leads to the common pathway. Clinical significance. The PT-INR is elevated in liver disease, warfarin use, vitamin K deficiency, and deficiencies in the extrinsic pathway or common pathway. PTT is elevated in hemophilias, unfractionated heparin, vitamin K deficiency, and von Willebrand factor. Understanding clotting factors can help quickly identify probable causes of coagulopathy. The intrinsic pathway is affected by deficiencies in factors 12, 11, 9, 8, or 4. This causes increases in PTT results. Factor 9 is vitamin K dependent. The extrinsic pathway is dependent on factor 3, 7, and 4. Factor 7 is vitamin K dependent. The common pathway is dependent on factors 10 in the presence of factor 5 and 4, factor 2 prothrombin, thrombin, factor 1 or fibrinogen, factor 1A or fibrin in the presence of factor 13 stabilizes the cross-linked fibrin. The common pathway can cause an increased PT or PTT. Heparin sulfate on the endothelial cell binds AT3 or antithrombin 3, which inactivates serine proteases. Active protein C and S binds to thrombomodulin and activates factors 8 and 5.